Welcome to the Wound Symposium for 2021. This presentation will be covering casting and compression. My name is Danielle Vlazny. I'm one of the physician assistants with the Gonda Vascular Wound Clinic, and I will be demonstrating a total contact cast on our pretend patient, and then we will also demonstrate several different types of compression therapy. So the objectives today are just a live demo for your visualization of how to apply a total contact cast. We specifically use the MediCast Ultra system, and then we will also do the compression live demonstration as well. For total contact casting, this is the gold standard for diabetic foot ulcerations on the plantar aspect of the foot. It's going to optimize offloading by enlarging the area of pressure and redistributing that from the foot up into the leg and throughout the entire base of the foot. Total contact casts come in many different options. We use a non-removable cast, but there are some options that have a removable version as well. There are indications for and contraindications to total contact casting. So like I said, diabetic ulcers are the main indication for total contact casting, but it can also be used in Charcot-arthropathies and postoperative care. We do not want to apply a total contact cast if we have an ischemic limb, if we have any exposed deeper structures such as bone or tendon, if the ulcer is deeper than it is wide, and if we have any active infection. So these are components that will need to be reevaluated at every cast application. This is a brief overview of how the total contact cast is applied for your reference, and we will go through this step by step in the demonstration. For cast management, we generally will apply the first cast and then change that between 2 and 3 days later, as the cast will reduce swelling in the extremity. After that initial change, then we usually go to weekly or twice weekly changes depending on how much exudate we have from the ulceration. Once the ulcer has healed, we will continue casting for 1 to 2 weeks after that to reduce the risk of recurrence and allow the newly healed tissue to mature. If we are casting for a Charcot-arthropathy, then casting can be stretched out to 2-week intervals instead of once a week. So we will begin the demonstration for the total contact cast now. I generally will have the patient start in a seated position. For this demonstration, we will have an ulcer on the bottom of the right foot. We have our total contact cast kit, and we'll have all the components available. So in every kit, you will have the instructions available step by step. So for your first few kits, that can be followed. And we'll also have the review of the indications and contraindications. You will also have a small piece of paper for specific removal instructions. And be sure to give this to your patient, as a total contact cast is not removed the same as a cast used for a broken bone. So to start out in this cast kit, you will want to find your medical grade foam. You can use this as the primary dressing or in addition to other dressings on the wound bed. You do want to keep the dressing thin. You'll then look for paper tape to start out with. You'll have a bandage, scissors, and then we have 2 different sized protective stockings, depending on the girth of your patient's leg. So the medical grade foam will be applied first. We will demonstrate on a 4-foot ulcer. So with the medical grade foam, you will want to trim that down to size for the ulceration. This will then be placed over the wound, and you use the paper tape to secure the dressing. You want to be sure when you tape this that the tape does not entirely come around the foot. So you always want to have a gap between the ends of the tape. And I always like to secure from 2 directions as possible to make sure that that does not shift. And we'll want to bring their pant leg up because the cast will be coming up to just above the widest part of the calf. So you'll always want to assess looking down where the widest part of the calf is and have a mental marker for where that cast is going to stop at the proximal aspect. If the patient has a bony prominence along the front of their shin, you can use the extra foam padding and place that over the shin for additional protection in that area. If you do that, then you can just use the paper tape again to hold that down. Now that we have the dressing in place, we will apply the first protective stocking. You want to leave a little bit at the end for the toes. As you apply this, you just want to make sure the foam is not rolling or bunching. You want enough above the top end of your cast so you'll be able to roll this down in a future step. I want to try to get all the wrinkles out of the stocking. Make sure that foam piece is nice and flat. And then if you have excess coming further back onto the foot and ankle area, that can be trimmed. Will land at about the midfoot. The kit also will include a set of plastic tape, and you can use that to secure the stocking toe end in place here. You want to keep that loose over the toes. Secure. In the bottom of the kit, you then have the protective padding layer that will go over the forefoot, and then the 2 malleolar pads for protection of the ankles, and that extends up the leg. I always try to place that over the malleolar prominences first, and then you will tape that in place. One over the dorsal foot, and I'll do 1 to 2 over the shin area, and then we want to secure the malleolar pads as well. Again, you want to make sure that your tape is not entirely encompassing the extremity and is not crisscrossing. So on this side, the tape went higher, and so on this side, we'll have the tape come around a little bit lower, and you can develop your own techniques for applying that. So then in the back of the leg, the tape is not crisscrossing at all. We have a little excess at the toe here that can be trimmed as needed, and in later steps, the excess at the proximal aspect will be folded into the rest of the cast. We then have the foam layer for toe protection. This has a plastic backing and an adhesive on it. So we fold this in half. I like to pre-fold it before putting it near the patient's foot. And then peel that layer off, and we will fold this over the toes. And then squeeze the edges together, almost making like a pirate's hat. And we will trim the excess from the sides. So I like to place my hand on the inside so I can guide as I'm cutting, so I don't risk injuring the patient at all. So we'll continue to trim up along the edge of the foot and follow that curvature. We'll come finish on both sides. So now we have the extra protection added to the toe area. Next will be 2 pieces of cotton batting for added protection around the foot and leg. And you'll just begin rolling those proximal to the foam padding for the toes. I'm trying to avoid getting significant creases. So with that cotton batting, if it's having trouble conforming, you can always just rip it and restart. Always try to get a uniform unit over the heel and ankle area. And then as you continue up the leg, you can usually just roll that continuously. And this is the piece where I like to remind myself where that cast is going to stop. So again, finding the widest part of the calf. So I'm going to probably stop my cast about here on this patient. So I'll add 1 more roll here just so I have that visual marker for me going forward as to how high I want to bring that cast. In a particularly bony patient, you can always add more padding through the ankle and foot as needed, but you are not required to use all of the padding in the casting kit. At this point then, I will usually have the patient roll onto their stomach. We'll have the leg bent for easier application of the cast. We want to try to keep the foot at about a 90-degree angle, and we want the ankle lined up with the leg. So we don't want the foot to deviate inward or outward, and we want to try to keep a 90-degree angle. And that's where a helper can be beneficial, helping to hold that foot in place as the patient is trying to relax. I will often use a sheet to protect the patient's clothing from the plaster and fiberglass components of the casting system. So we'll just drape that over the patient's clothing. And so I see here there's a little bit of a gap on the ankle. So I do have some extra padding, and we will just be sure we cover that so it's adequately protected. You'll want to make sure you have a bucket of warm water. Generally, we will go between 78 and 85 degrees for the water temperature. Then from the cast kit, the first layer to be applied will be the plaster roll. And so this will be dunked directly into your water. So you always want to make sure you hang on to the leading edge of the plaster roll. Completely submerge in the water for a few seconds. Bring that back out and squeeze that out. We don't want any excess water. That's going to decrease the drying time if we squeeze out all that excess. So make sure you hang on to that leading edge. And then we'll bring that in and start just about the toe protector. And we will start wrapping circumferentially. So if you want to hold her toe down, thank you. Help keep that foot at a 90-degree angle. You want about a 50% overlap on the plaster. The ankle can be the hardest section to go through because of the angle with keeping the foot at a 90-degree angle. You want to continue to overlap as we're coming down the leg. If you start to get a gap here, you can see how that kind of top edge is not adhering compared to the bottom because of the shape of the leg. You'll want to try to correct that over your area of padding. So that would be that front pad. And so you can form a fold on the front to bring that wrap back into alignment to continue. And again, I ended my padding approximately where I want to end the cast based on her calf size. And so additional plaster can just be brought back down the leg. And then generally I will change gloves at this point because these ones are covered in plaster. So always good to have a second pair handy. The next layer will be the first fiberglass layer, and this is the 3-inch fiberglass layer from the cast kit. Again, in roll form, you want to make sure you hang on to that leading edge. We will dunk in the water. It's a little hard to hear, but you'll notice bubbles. So kind of roll the piece back and forth to get all those bubbles out. And again, squeeze out all the excess water, hanging on to that leading edge of the fiberglass. This will roll right over the plaster overlay. And you want to bring that up to the same level as the first plaster layer. You can always get a little bit extra water, make sure that fiberglass is adhering to itself, give it a nice little rub to activate. The next layer we will apply is the first fiberglass pre-cut splint. And so this will roll out into one long fiberglass sheet here. You'll place the bottom at the proximal end of the cast, go over the heel, and then wrap over the toe. So for this patient, we have excess through this region, so we will trim that back. So that's landing on the forefoot. And then we will also want to trim the edges because then as we're wrapping the cast, those will lay flatter if we can remove these pucker areas. Then you will want to find the arch of the foot. And so you can feel back from the heel where that starts and then from the front where that ends. And we will make little cuts in on both sides. And you're going to about the midfoot with these cuts. And then this piece will be turned underneath to fill in that arch and provide support for the peg that will come next. We will then have another splint layer. So this will be identical to the first. I'll roll that out. Usually try to look about 2/3. Fold that back. And we're going to trim an opening for the peg. As you do this more and more, you'll get an idea of how much you need to fold and where you need to trim that back. I usually will go down about 3.5 inches. So we have both a strike plate, which is the dark piece, and that will go down first. And then we have the peg for support when taking any steps or transitioning, and that will lay over the top of the foot plate. The gap in the middle between the two peg pieces should be aligned with the anterior tibial crest. So we want to bring this down in a straight line to the tibial crest. And so for this patient, we'll move that just slightly back here. So the midline here is coming down to line up with the tibial crest. Then we will apply the second splint, again aligning with what will be the top of the cast, bringing that over. We want to widen that around the peg. And if you need additional trimming in this area to make sure that that peg is fully exposed. So you want to make sure that completely comes down on the side so we don't have any little fiberglass pieces sticking up, because those will be slippery if they come in contact with the ground. And again, we will want to trim the puckers on the side. Then we will take that excess stockinette and padding and roll this over the top of the cast, sealing in those underlayers. Make sure that fiberglass splint lays flush. And then you'll have your final piece, which is the 4-inch fiberglass roll. Again, this will be one that we need to submerge, hanging on to the leading edge. Listen for those bubbles till you get all the air out. Bring that out, squeeze out the excess water. And again, hang on to your leading edge, and we will start securing the final piece, holding those fiberglass splints in place. As we're coming to this middle piece of the peg, I will give 2 turns to the fiberglass roll, and that will help it to fit down in between the 2 pegs, and then we can continue with the wrapping. Again, want to make sure you're holding that fiberglass down around the edges as much as possible. And then hold that fiberglass splint in the back. Keep that flush against the leg. And then you want to bring that right up to the edge of the cast. Try not to go over the sock at all, because then that can dig into the patient's skin, and you can just bring any excess back down the cast. Just get your fingers a little wet, rub that cast, seal all those fiberglass layers together. Go back, make sure everything is lying flat around the peg. That is the completion of your total contact cast. This will then have the patient roll back over and dangle their legs off the edge of the bed, and we generally will wait 15 to 20 minutes to assure the cast has solidified and dried enough for them to begin weight bearing. As the cast is drying, then we will just want to assure the patient is not noting any areas of discomfort, pinching. She's not noting any loosening or shifting of the cast while it is drying. As long as there are no issues, once the cast is dry, then the patient can be dismissed with their offloading device. So for the next portion of this presentation, we'll focus on lower extremity compression. So this is circumferential extrinsic support to help reduce lower extremity edema. Compression overall helps to manage venous disease, lymphedema, lipedema, and edema related to other comorbidities such as heart failure. There's a multitude of different types of compression, and for this demonstration, we will show how to use low stretch wraps and ACE wraps. The various goals of edema management. This is helping to heal with ulcerations, reducing the risk of cellulitis associated with edema, and managing patients' quality of life and limb girth. Edema is a long-term issue and usually is not cured, but is managed through the use of various types of compression. Throughout a patient's clinical course, their edema can wax and wane, and this will require use of different types of compression. So it's always a question of when can compression be used, and it's easier to define when not to use compression. So if patients are admitted or in decompensated or florid heart failure, we would not apply compression immediately at that time. If we have an ischemic limb with an ABI less than 0.5, we don't use aggressive compression in that situation. And some patients just have difficulty, particularly in the setting of ulcerations, with tolerating compression. And we try to use different modalities to make that as comfortable for them as possible to increase compliance. So we have different types of compression, depending on what the goal of the compression is. When we initially have a patient with significant edema, we want to reduce the limb girth. And so for that, we will either utilize ACE wraps or a low stretch wrap, or short stretch is the other name. If we already have most of the edema out of the patient's leg and our goal is maintenance, then we will often use compression stockings or additional devices such as Velcro compression wraps. The types of wraps for reducing limb girth include the ACE wrap, and so this will be a bulkier wrap. It's called a high stretch wrap because it has a lot of elasticity to it. And so when you take this out of the packaging, give it a good stretch, and you can see there's a lot of elasticity to this wrap. When this is placed on a patient's leg, we will have a high resting pressure because of the elasticity in the compression. But when they are up and walking around, we have a low pressure because this elasticity will also give as they're flexing their calf and walking around. So we tend to use this on inactive bedbound patients. The difference then is the low stretch wrap, where we're not getting as much elasticity to the wrap. And so when we apply this, the pressure when the patient is not active is low, as we don't have a whole lot of compression, a whole lot of stretch to this wrap. As they are moving around, we have a stiff exterior compression wrap, and that internal calf contraction will then increase the working pressure and make the pressure high when they are ambulatory. So we will use this on patients that are remaining active. We can use additional adjuncts to increase compression, such as strategic placement of ABD pads to add bulk over areas of wounds or fibrosis. We can use foam for protection and increasing the stiffness of compression. And you can also use cotton batting for additional protection from the compression. If we are going into a maintenance mode, then we will use compression stockings. Medical grade compression starts at a 20-30 strength, and you can also escalate that to a 30-40 strength. There are many different lengths of compression. When focusing on edema control, a knee-high compression stocking is generally adequate. We can progress to a thigh-high compression stocking for patients with proximal wounds, varicose veins, or significant venous disease. Then you can also use a pantyhose waist-high length as well, or there are also capri options often used in more of a lymphedema setting. These are some additional Velcro compression devices that can be used if patients have trouble donning stockings. These Velcro compression wraps will pull over the leg, and then they have several different pieces for closure that crisscross on the anterior shin. They come with a foot piece, as you can see in the photo, or they may come with a stockinette to add additional compression throughout the foot and ankle before that joins the Velcro wrap continuing up the leg. Advanced compression can include the use of different types of foam materials to help with fibrosis and lipodermatosclerosis. You can also use multi-layer wrap systems, which would be similar to an Uniboot system. And similar to using ABD pads, we can use different foams or malleolar pads for added compression over difficult areas. Another advanced therapy would be progressing to venous or lymphedema pumps. Compression can be difficult in terms of patient compliance. It can also be difficult when the patient is managing it at home. So often things that we'll see that aren't quite going as expected for the patient is wrapping from the knee down instead of the foot up, as we want to create a pressure gradient where we're forcing that fluid out of the lower extremity. Patients will sometimes be reluctant to include the foot, which can create some tourniquet effect at the ankle and actually increase edema in the foot. When using wraps, we may be getting insufficient overlap, and with excess swelling that can cause bulging or breakthrough of tissue and cause blistering and damage to the skin. Wraps will shift over time, especially depending on the patient's activity, and so they may need to be rewrapped throughout the day, which also can be difficult for patient compliance. With compression stockings, the main difficulty can be having enough oomph to get a high compression stocking over the foot and up the leg. And there are multiple different types of devices available for assistance. And rubber gloves are also another good, cost-effective device to use just to provide a little bit more grip and traction on the stockings. And so now I will demonstrate how to apply the ACE compression wrap and then the low stretch system. And so we always start with some form of protective stocking to apply next to the patient's skin so we don't irritate and have any tissue breakdown because of the wraps. Depending on the patient's comorbidities, we may look to flip this inside out if we're using a stocking like this, to avoid any rubbing of the seam on the toes and cause any skin irritation that way. So this will just be applied like a regular sock. This is just a basic white liner sock. There's no compression in this sock. Again, you want to just try to make sure you get any kind of wrinkles out. Keep that loose around the toes. If we're applying low stretch compression wraps, then we usually start with a narrower wrap. So this is an 8-centimeter wrap to initially start around the ankle and foot. So when starting the wrap, we want to move from the base of the toes proximally. And so we'll want to take that first leading edge and come across the top of the foot, and then you'll want to begin your overlap. Generally around the foot, we'll look to use what's called a figure of 8 pattern. So coming high, crossing low, coming low, crossing high, and continuing up the foot, crisscrossing back and forth. We want to make sure when we wrap the ankle, aim for about half the ankle in one wrap, and come around and get the second half in the next wrap. Continue that crisscrossing pattern. With the low stretch wraps, you don't have a lot of tug. You want to try to apply a little bit more as you're going through the lower part of the foot and ankle, and then coming up, and that initial wrap will stop just above the ankle. We like to secure that in place with the use of tape. Then to continue the compression up the leg, we will transition to a wider low stretch wrap. So this will be a 10-centimeter wrap. Again, want to start with that leading edge and continue that crisscross pattern up the leg. The other option would be a spiral wrap, and that will just kind of look like a barbershop pole, continuing up the leg. And again, we will tape that final edge in place. Ideally, we want to bring the compression up to just below the knee. For wraps and stocks, you want to try to stay about 2 finger widths below the back of the knee. We don't want compression to come into that popliteal fossa and cause any irritation to the patient. So if you want to take a closer look here, we have that nice crisscross figure of 8 pattern going up the leg with the compression. So the next demonstration then will be the high stretch or ACE wraps. And these again are used on inactive patients. So very similar wrap to the low stretch. Generally the rolls are large enough that you only need 1 wrap for the entire leg. So again, you'll want to start at the base of the toes, bring that leading edge across the top of the foot, and this is where stretch is important to monitor. So we want to try to get a fairly high stretch, but not a complete stretch in the foot. We're going to aim for about 60%. And as we bring that through the foot, we just want to maintain that stretch as we're going around. So again, check your stretch when you come back through. As we're coming up the leg, then we will want to try to decrease that stretch a bit, because we're wanting to try to mimic that pressure gradient like we find in compression stockings. As you can see, not much stretch as we come up the leg. We're decreasing that as you come closer to the knee area. Again, we will secure with tape. And as you can see here again, we have that uniform figure of 8 running down the leg for the compression. The ACE wrap can also be applied in the spiral form, going up the leg. And again, that will just be a continuous one-way wrap coming up the leg without that crisscross pattern present. Thank you for watching the demonstrations. My contact information is available in the PowerPoint if you have questions at any time. Thank you.